Welcome to Health Sciences Update, a program about health sciences education and research on the Washington State University Spokane campus. I'm Doug Nadvornik. WSU's new Elson S. Floyd College of Medicine will have its administrative headquarters in Spokane, but it will truly be a statewide institution with clinical campuses in Spokane, Tri-Cities, Vancouver, and Everett. Here to talk about that is Ken Roberts, who is the college's Vice Dean for Academic and Community Partnerships. So Ken, what's a clinical campus?
A clinical campus, as we talk about it inside the medical school, is a place where students go to do their clinical training, which is typically in the last half of medical school. So historically that's years 3 and 4.
And so will they literally be on the campus in those cities?
Well, campus is kind of two things when we talk about clinical campuses. We'll have clinical campuses in Spokane, where our main medical school is here. We'll also have them in Vancouver, Tri-Cities, and Everett. And all four of those places, WSU has campuses. And so part of the student experience will be tethered to the actual WSU campus. And probably the majority of it will actually be in the hospitals in those communities. So when we say clinical campus, we're sort of describing the whole thing. The hospitals and clinics where the students train, and also our campus there where the students will have a chance to do classroom work and hear talks and participate in small groups and so forth.
So what's involved in putting together a clinical campus, and how do you fit into that?
Well, my job in the Office of Academic and Community Partnerships, and the reason those two words, academic and community, are in the title is I'm working with both the WSU campus, the chancellor and his staff, to make sure we have the resources we need on the campus to host, to have the medical school students as part of what happens on their campus. And this is things like a classroom where they can meet, a place where they can go to study, places where they can access IT help in the library and so forth. And then the other part is clinical partners, where we have affiliation agreements with a hospital or a clinic, physician faculty who will teach our students, and in those settings the students go in and participate in those clinical activities to gain that experience. So they're doing really two things. Probably 80% of their time they're in the hospital or clinic. The rest of the time they're interacting on campus, and together that's their clinical campus experience.
So what about the infrastructure needed on campus? Does anything need to be built? What about the human infrastructure, that sort of thing?
Nothing needs to be built, and that's one of the great things about starting the medical school here at WSU is that the facilities that we've needed to start this are already in place. And we talked a lot about that with reference to Spokane. The buildings and labs and so forth that we need for years 1 and 2 are here and in place. But also, because we have the campuses in the other locations, the physical infrastructure is also there. So nothing needed to be built. Because we're a community-based medical school, we're not planning to build hospitals or anything like that. We're doing that in partnership with our partners in the community. So the students will be in hospitals and clinics that are already existing in those 4 locations, and so nothing needs to be built there. The human part of this, however, is very important. So we need faculty for our College of Medicine who are physicians in practice, who want to teach medical students. And so we're in the process now of identifying those faculty members, getting them appointed to the medical school, and we'll be embarking on faculty development so that they're ready to teach our students when our students get to them in their clinical years.
So they're expecting to see students in their 3rd year. Will they see students before then at all, or will it all be cold in that 3rd year for them?
That is when the majority of the clinical training takes place, years 3 and 4. But like all really modern medical schools these days with new curricula, the emphasis is on the students having clinical experiences from their first day of medical school on through. So that means robust access to clinical experiences in years 1 and 2 as well. Now, in years 1 and 2, it's not nearly as much as years 3 and 4, but they're still in those clinical settings. So we made a decision in the College of Medicine at WSU that we would like our students to not just be exposed to the clinical settings in year 1 and 2, but to have at least part of that exposure be at the other 4 at the 4 campuses. So we're planning intersession weeks in the curriculum where the students will be able to take a full week, go to the clinical campus where they will eventually do their 3rd and 4th year, and have early clinical experiences. So the idea is that they come to know those communities, they get familiar with the hospitals and clinics, they know some of their preceptors so that when they do arrive in year 3, it's just part of a continuum. They're comfortable there already, and everybody is comfortable with them, and there's no break in their training, so to speak.
So when do students find out which of those campuses they're going to spend their last 2 years at?
Well, to be fair, I think we haven't absolutely finalized this, but the discussion right now is that we really want them to know which of the 4 campuses they'll do their clinical training on when they matriculate as a first-year student. So that will allow us to send them to those sites in year 1 and year 2, knowing that that's where they'll be in year 3 and year 4. So the question I always get, and maybe you're going to ask it next, is how do we choose? And we're still working on that as well. It'd probably be more than one factor goes into that decision. But we would like them to know when they get accepted, or shortly thereafter, which of the 4 cities that they'll spend the majority of their time in, so before they even start.
So the WSU Medical School is patterned after Florida State, which is a similar model. Can you tell us about what Florida State has learned about putting students in for a long period of time at one area?
Well, that's a great question, and it's one of the reasons that we looked at Florida State, is because we knew from discussions with them that this has worked very well to accomplish their mission. And their mission really was very similar to ours, to create a cohort of physicians where most of them are interested in primary care, and a cohort of them are interested in primary care in smaller places, so rural settings and underserved, sort of as a general category. What Florida State has discovered, and something that we're planning to emulate, is that when you send students out to the community setting in other cities and allow them to stay there for their entire 3rd and 4th year, or the majority of it, your retention rate, or in other words, keeping those physicians there or having them return once they complete all their training, is much, much higher than if you train them all in one setting, then expect them to, migrate out, if you will. So their experience with this has been very positive in that respect, and we're expecting similar results in our program.
So when you had to go out and start selling this to those clinical partners, what was the range of answers you got from them?
Very encouraging. So, because that was the real question when we first went out, is what will be the reception to the idea of having medical students from WSU training in their community, and physicians. When you ask a physician to be faculty and to take a student and teach them, be it internal medicine or pediatrics or family medicine, whatever, it takes time, and it takes time out of an otherwise very busy day. So this is a decision with consequences for those who choose to be clinical faculty. And so we know what we're asking for, and we know that no is a legitimate answer. But what we've discovered is that there's a tremendous enthusiasm for having students. And physicians who teach and like to teach, having the student is a great part of what they do. And physicians, as you know, as part of their oath that they take to the profession, and as part of how they're trained, through the process, they're trained by fellow physicians or those further down the pipe than they. So there's an expectation for many of them that they will give back in this respect. So to answer your question, the reception generally has been very positive, and we're now in the process of appointing those faculty in these different areas for our first cohort of students. Lots of things to still work out. Faculty development, making sure that the faculty that we have know how to teach in the model that we're proposing for a curriculum and so forth. But the enthusiasm is there, and we're very gratified by that.
So one other thing is you've got deans in each of those cities. It's not just the dean is in Spokane and everybody answers to Spokane. Talk about that a little bit.
Yeah, so it's a distributed administrative model. It's not terribly dissimilar to how WSU as a system functions across our 5 campuses as well. But in the medical school, we will have a chief administrator at each of the 4 sites whose responsibility is the educational program for the clinical years 3 and 4. That person is usually referred to as a regional dean or a clinical site dean, something like that. An associate dean level person in our system. And they will have, reporting to them, the various physicians who are in charge of the different areas of medicine that the students are training in and so forth. But basically what you build is you build an administrative structure that's local. And this is one of the things that we're really emphasizing in our structure, is that we are a medical school in 4 locations. So if you're in Vancouver, your administration is in Vancouver. You have any kind of a problem that you need help with, it gets solved in Vancouver. And so there's a sense of place and a sense that our medical school is not in Spokane and reaching out to Vancouver, but our medical school actually has a presence in Vancouver with a campus in Vancouver, just using Vancouver as an example.
So what about some of the smaller areas? I mean, if you've got the student, for example, in Vancouver, what are their chances of going to, say, the coast or over to Longview or somewhere in that area? Are you looking at smaller distributed places for them to practice?
Absolutely, and we're looking, right now with some intensity because we want that to be an option for our students to be able to have a lot of their clinical training occur in smaller places. So one of the ways we think about this is each of our 4 locations really serves as an anchor or a hub where the students can very easily get the full spectrum of clinical experiences that they need. But if we look around those cities, you can find smaller towns quite readily, within an easy hour's drive or less, where the town is much smaller and the setting is, the kinds of settings we'd want students to experience if they're going to learn to practice medicine, say in a rural place. So our initial strategy is to have students be allowed to do clinical experiences, kind of spoken out from their main campus. And then beyond that, we're just having really open discussions about how we might be able to place students for various period of times in really fairly rural places much further away. Now that's more of a challenge because you can't expect a student to drive a couple hours every day or anything like that. But there are ways that you can create opportunities for these experiences to be had, and it's really the heart of our mission to give students the educational experiences that would nurture their otherwise mission that's inside of them to practice in smaller places. It dovetails with admissions. I mean, we want students coming to us from the smaller places who want an opportunity to have a training experience back.
So in most of those areas, they're going to practice primary care because that's what small town medicine generally is. But for those who decide that maybe they want to do more of a specialty, will you have specialty options for at some of those clinical campuses?
Oh, absolutely. So as a medical school, we're required to give students the full spectrum education in all the clinical specialties. And in the 3rd year, that's the main things, like medicine and peds and OB and so forth. But as they enter the 4th year, they should have an opportunity to experience other specialties that are more niche, orthopedics or head and neck surgery or things like that. So those opportunities will be available to them in these larger settings where we have our clinical campuses. And we know that not every one of our graduates is going to go into primary care. No medical school produces 100% that way. We're setting up our curriculum to emphasize it. We're setting up our admissions also to emphasize it because we really want that to be a robust component of what we're graduating. But for those who gravitate to other things, they will have those experiences as well.
So, and just in our last 30 seconds or so, will there be sort of specialty areas? Would the Tri-Cities, for example, be known as for one particular area, or Vancouver or Everett, or will they have their own unique sort of identity, you think?
Well, that's a great question. I probably can't fairly answer it now because we haven't started, but I'm actually hoping that what you described does in fact happen because each of these places is different. And they all have, I'm sure, different strengths and weaknesses, that will morph over time into, reasons to go there for a particular thing. I especially think about this around how we build faculty and so forth. If you think about the Tri-Cities, Pacific National Labs is there with a lot of health-related research going on, in different areas that might attract students for a particular reason. Vancouver being in proximity to Portland and so forth, there's going to be opportunities that evolve. Everett, obviously, with a lot of engineering and so forth there. I can see all sorts of things that could happen over time. We're not going into this with necessarily any preconceived ideas around that, but one of the things we're really encouraging, and I'm very optimistic this will happen, is that each of our sites will develop a personality, will develop certain attractions to students, and will embrace students in their own unique ways. So we want every one of our campuses to be a destination campus.
Ken Roberts is the Vice Dean for Academic and Community Partnerships for the Elson S. Floyd College of Medicine at Washington State University. This is Health Sciences Update.